As we discussed earlier, some industries experience a displacement of jobs as a result of increased automation. But in sectors like telehealth, big deal telehealth, particularly in rural areas, technology is making it easier to hire, among others, critical care specialists. Our next guest is Deanna Larson, CEO of Avera eCARE, one of South Dakota's leading telehealth providers. Avera eCARE has 6 healthcare service lines that service more than 420 locations in 32 states. They are huge. Deanna, it's great to meet you and to talk about, I mean, we were talking a little bit earlier about how the pandemic kind of made us be more real about living on digital platforms. A lot of people talked about it before, but a big chunk of the country was not there. Now we're all there, and particularly in things we need like health. How has that ecosystem evolved and developed this past year from your perspective? Tell us the Avera story.
Oh, I'm delighted to be here and share the story with you. So the big story really is there's 2 parts of this, maybe 3, but the first 2 are the most important. So our providers were really enabled and had very little choice if they wanted to be in connection with their patients. And the consumers, or the patients, had very little choice if they wanted to be in connection with their doctors. And so the telehealth platforms were made available. There was access available to the physicians getting back to their patients and vice versa. So what all of a sudden happened is the brick and mortar were closed down. People who maybe questioned or wondered, would this really work for me? All of a sudden, that was the best access source. It was the safest. It provided confidentiality. And so between those 2 things, they were able to talk with their physicians and our nursing staff, ask questions. And we're really able to be connected in a very easy way, even easier than going to the brick and mortar and even easier than being unnecessarily exposed. So it was a really quick turnaround if you think about what was consuming, the whole nation just that many months ago.
I mean, we were just discussing a moment ago with Keith Kroc, the importance of trust, and as we develop these new systems, and in part regulation is out there to protect the public, but there's a balance with innovation and trying to do it. Are we getting it right between the regulatory side of health and doctors connecting, healthcare providers connecting online through providers like yourself? Is that about right, or do you find the government a bit slow?
That's a tough question.
It's what I do.
Every day you hear the hacking story, right?
Yeah.
Someone was hacked into, someone's identity was lost because of a hacking situation. So it's very long been the healthcare community's requirement to keep the confidentiality of patients' information. And so I do believe it's very important that we have the regulatory process so that patients' information can be safe and secure. They have the confidentiality they need to have the right discussions with their clinicians. And I also think it's very important that we push, the process consistent so that patients don't necessarily get exposed to maybe imposters as a physician imposter trying to say that they're a clinician, physician, and make themselves available, and patients are seeing someone who's not a physician. So I have a high regard and respect for that regulatory process. Do I think we could go faster and make those things happen? If you knew me at all, you would know I always want to push the metal, the pedal to the metal to make it go faster.
Oh, that sounds cool. I'm all with you on that. Deanna, let me ask you another question. We've also talked this past year a lot about how COVID disproportionately impacted certain communities and about realities in healthcare in the country that are uneven, particularly with Black and brown communities and different parts, the rural-urban divide, et cetera. Are there ways that we can leapfrog some of those problems and really solve some of that imbalance if we were to embrace your industry more than we have thus far?
Oh, I absolutely think, access is a real issue. So access, because you can't drive across a country, so to speak, in our rural geography, or access because you can't leave home as a young mother with several babies or individuals you're required to take care of. So access is always an issue, and it doesn't really matter where you live. And then the next really big issue is, do I have access to bandwidth or connectivity that's going to get me to the right level provider that I can trust? And So, FCC funding and some of those really important assets around bandwidth and, Elon Musk putting the satellite opportunity in space for us for connectivity. Those are huge things that are going to be important across the nation and the world, really, for continued access and, again, high-level, high-quality access.
You've become so big. I mean, you're the world's largest thing of this. You're like a conglomerate now. Different dimensions of the healthcare space. But one of them that I'm interested in is the Avera eCARE Center. That's like a virtual hospital. So you have doctors, you have nurses, you have pharmacists, you have other healthcare doing this. Does this begin to replace brick and mortar? Does it supplement brick and mortar? I'm just sort of interested in the notion, is this the future that we're going to move into where hospitals are virtual per se? Because so much is, not I'm just interested in this dynamic. I want to visit. I don't even like going to a brick and mortar doctor. I'd love to just do it online.
Mm-hmm. Let's start at the beginning of the problem. There's too many patients that outnumber the amount of providers, and especially the more specialty you get. So if you get at the highest level of subspecialty, there's not enough of them, and our trajectory is indicating there's going to be fewer available to that population. So it's so important to think about augmenting those clinicians. So we have these brilliant individuals in this industry of healthcare who go and get their education, and I think that telehealth, what it does is it augments the opportunity for those highly educated, and this, I could be talking about an RN, or I could be talking about a subspecialist peds rheumatologist, making sure that those individuals have access to patients who need them, because the workforce shortage is real. The need for healthcare and the cost of healthcare is real. So how do we augment workforce multiply through telemedicine to provide that important access where we can do that without brick and mortar? Do I think it'll replace brick and mortar? Never. Do I think it will augment and support easier access to healthcare than asking early questions about what's going on with you or your child? Do I need to see you now? Should I wait and come later? And if I do need to come in, where's the best access point? Do I go to the ED? Do I go to a primary care provider? Do I go right to a specialist because my need is so urgent? Those kinds of things I think consumers want all the time. And if you think about it, oftentimes we have a consumer who's all of a sudden shows up at maybe an infectious disease doctor, and they're saying, oh, gee, you should have went to rheumatology or urology, and a lot of time is lost in the process there. So how do we really help navigate? Can that be done on telemedicine, telephone, and really reduce the cost by not sending people all over, if you will, to a lot of brick and mortar? I really think it simplifies the consumer's life. It simplifies the healthcare profession's life as well, because they want to see the patients whom they can best help. In Sioux Falls, we do have all of those things I just said. I had nurses, pharmacists, boarded ED physicians, critical care intensivists, hospital medicine. But they are working in collegiality with those 400-some communities you mentioned. They aren't providing all of the care. They're working in an augmented style. So in maybe a rural community, we have a nurse practitioner who's supporting the overnight care in the emergency department, while the local community physician is not required to be in that hospital. Our boarded ED doc is, there at the touch of a button to support the care that's being provided there, and it gives the opportunity for us to call in the local provider if that's what's needed, or to not call them in, being reminded that that local provider is more than likely a primary care provider working all day in the clinic, working all day taking care of hospitalized patients, and then trying to go home, and yet still being required to be available on night, 24/7 emergency call. Now, it's not that they aren't capable of taking care of the majority of emergency, visits that come in, but just take into consideration, they're also then the highest level individual in the community to take care of car crashes, heart attacks, strokes, those things. Where again, if you were in a more urban setting, the boarded ED doc, who that's what they do every day, would have the support of a neurologist, a stroke neurologist, a cardiologist, etc. So what we're doing in that small community hospital is supporting the nurse practitioner while they're waiting, if needed, the local provider will come in. We've already brought in the stroke neurologist or the cardiologist to determine if this is a truly an MI, and actually even maybe supported the air transport to get to that small community hospital, getting that patient very quickly to cath lab. On the other hand, let's say our boarded ED doc works with that nurse practitioner and says, well, I think this is something that you can work with locally here and stabilize, and we'll be here to support you and help you out. In that case, the physician who's home for the evening may not have to come into the hospital till the next morning, and would work in a collaborative style with the ED doc here in Sioux Falls, or the hospital medicine physician who's just a row away from them, who will then accept that patient and help admit and support that patient or in the overnight hospital setting. So you see what we just did. We just workforce augmented or workforce multiplied very capable and high-level individuals to support the care of that individual patient.
Well, Deanna, you've just accomplished something that I think was not possible. You made me very instantly comfortable with the notion of eCARE. When you kind of think about all the different, for me it's efficient, but I don't know if it's going to feel as comprehensive. And there are a lot of things that I don't know. You address the literacy issues. A lot of people going to this may not know which choices to make. They waste time. It's more than inefficient. It's that the system can't count on the patient knowing everything, and you just described that. I really, really appreciate the journey that you took us through. I hope you'll have us back, and then you'll join us again, and I can go on an e-tour through many of the other divisions. But Deanna Larson, CEO of Avera eCARE, thank you so much for joining us today.
Thank you so much. You're welcome to visit anytime.
Absolutely. Well, that brings us to the end of our program today. What a great set of conversations. A big thank you to Nokia for its support of this program, and to all of you in the audience for joining us. For any of you who missed these conversations, we're going to have them up on our video on our website shortly. I'm Steve Clemons. Be well.